Hello, welcome. My name is Matt Lampa, and I am really excited to be here and to be a part of Class 2021. Thanks, Contomac, for allowing me to be here. So what we're going to cover today might, on initial glance, seem kind of a little funny, and that is the title of the presentation is When Scleral Lenses Fail. You might be kind of wondering, scleral lenses are kind of amazing. There's plenty of speakers covering all sorts of topics related to scleral lenses this year at CLASS, in previous years at CLASS, and many other conferences around the world. And scleral lenses most certainly have their place in clinical practice. Some of the things that we're able to accomplish in scleral lenses are edging on amazing. So there are times, though, when scleral lenses might not be the best choice, or maybe there are things, some complications that result because of scleral lens wear where we as the clinician are intentionally forced to fit a patient into a different style of contact lens, or just maybe a different contact lens modality altogether. What I want to try to do today is think about scleral lenses initially here in really two main groups, kind of two categories. And the first category that we kind of think to put in scleral lenses are those individuals with irregular astigmatism. And it's that irregular astigmatism that really doesn't allow them to see with standard spectacle lenses, and really doesn't allow them to see with standard soft contact lenses. So we, as the prescribing eye care practitioner, are now fitting that patient into some specialty product. And scleral lenses, due to their non-flexing, rigid nature, can just be awesome in terms of visual performance in these individuals with irregular astigmatism, whether it's left behind by injury, surgery, or disease. And as soon as we put that patient into some non-flexing rigid lens, whether it's a scleral lens or some other rigid modality, that's when they instantly see 20/20 and can really be that life-transforming vision modality that they need. There's another indication here in terms of scleral lenses that we do need to mention, and that is those individuals that have some kind of ocular surface disease, because it's really that scleral lens that serves as a bit of a moisture chamber holding whatever fluid we fill the bowl of that scleral lens with on initial application. It remains against the eye, bathing the eye in that solution during the time it's worn, and can really be transforming for those individuals with ocular surface disease like we see on this slide here a number of months later, or even this example and the next one are really kind of hard to believe. But this is a patient who has a history of Stevens-Johnson syndrome. You see on initial visit in the top left, and then 6 months later, how much clearer, relatively speaking, their eye is, and then also how much better their visual acuity is with that scleral lens on just after 6 months. And then this next patient here, also edging on amazing as far as transformation, is this patient who has a history of ocular cicatricial pemphigoid pre and post scleral lens wear. It's almost hard to identify that as the same eye. I guess my point here is that there is a place for scleral lenses in clinical practice, but it isn't necessarily the tool that gets used 100% of the time. So what are some of those complications? Well, here's a list of them. Some of these are fairly easily remedied. Some of them maybe not so. Maybe some of these scleral complications are the ones that end up being the deal breaker for us. Maybe this is the reason why the patient isn't going to be successful in that scleral lens, and now they've kind of won the right to wear a different product. So here today, I think in modern clinical practice, we find ourselves as a bit of a crossroads. And that crossroads we find ourselves with, particularly when it comes to those individuals with irregular astigmatism, is do we go down the path of scleral lenses, or do we go down the path of rigid corneal lenses? But is there something that can help guide that decision-making process, maybe even before we place a contact lens on the eye? Because we need that non-flexing nature of the rigid lens, whether it's scleral, whether it's a corneal contact lens, whether it's a hybrid lens or some piggybacking modality. We do need that non-flexing nature of the rigid lens to give us that optimum endpoint visual acuity. So the question remains, is there a way to predetermine the success of a scleral lens, or maybe we should kind of stick with the traditional path and go more towards the corneal contact lens? And this was a question that we set out to answer a number of years ago at Pacific University in Oregon. And our hope was, could we avoid the picture that we see on the slide before us? Is that we know we need a corneal contact lens to be supported by the cornea itself. So is there some way to know, is there enough symmetry within the cornea to support the physical fit of the corneal contact lens? Or maybe there's so much asymmetry to the patient's cornea that we can't support the physical fit of a corneal contact lens. And then now what we actually need to do is use the more sort of regular, or I guess better said, unaffected sclera to support the physical fit of the contact lens, and use the sclera to support the physical fit of the contact lens. And I think the question really starts to get answered here in terms of topography when we look at the eye in two different ways. Way number one is what you see on the left-hand side of the screen, the axial display, or the other way to think about it is the power map. This is really most default displays in our modern corneal topography system. And what it is essentially a picture of what the patient is predicted to see based on the shape of their eye. It's really truly that power profile of the eye. So the steeper the cornea, relatively speaking, the more minus power it needs to correct it. Flatter the cornea, relatively speaking, more plus power is needed to correct that portion. And it's really that asymmetry within the patient's pupil and over their visual axis that leads us down the path of irregular astigmatism, whether it's injury, surgery, or disease that led to that point. So do we now maybe make the prediction that the reason why the patient is seeing so poorly is truly because of their cornea? So if we look at the map on the right, it's the exact same patient, it's the exact same eye, taken at the exact same time. It's just the topographer's thinking about the eye in a different way. And we term this the elevation display, or sometimes called the height map. And what it's really telling us is how high or low we are on the patient's cornea. The more red that we see, the higher, relatively speaking, in terms of elevation. The blue, the cooler colors, the lower we are in terms of the cornea. But the hard part that's difficult to get our mind's eye around is what's its reference? Where is the reference taken from in terms of the elevation? If we use the analogy of a topography map of a mountain, for example, there's really two pieces of information on that topography map that are helpful for us. Number one is where those lines get really close together, means the mountain's changing curvature really fast. It's really steep. The other thing that we see on there where the lines get further apart means the mountain kind of plateaus out or flattens out. In terms of the analogy here, that's really our axial display. So we use color instead of the lines. So where the cornea is the steepest, it's the reddest. Where the cornea is the flattest, it's the bluest. If we use that analogy of the topography map of a mountain, the other piece of information that's on that map is the elevation. How high or low are we on that mountain? But that reference is taken from somewhere. And in terms of the elevation map of a mountain, it's taken from sea level. That's the reference. That's the 0 point. So when we look at the topography map of a mountain, it's just like we see here. There's really two very important pieces of information. Curvature, where the lines are. Elevation is the literal number we are in terms of elevation above sea level. What is a little difficult to get our head around, though, is just because an area of the mountain or an area of the cornea is steep doesn't necessarily mean it's the highest. For example, we might have the mountain come right out of the ocean and it's really steep, changing curvature really fast. Conversely, you might be in terms of really high up on the mountain, but it's this high alpine meadow. It's it's a plateau, but relatively speaking, it's higher above sea level, but relatively speaking, pretty flat. So what about in terms of the corneal topography system? What's the reference? What's sea level, if you will? Well, what this is a reference surface. It's what's referred to as a reference sphere, and it's a theoretical spherical surface that's dropped down onto the surface of the cornea. And then the topographer asks a very important question, and that is if it has to measure down from that point of the reference sphere, it assigns it a blue color. If, though, it has to measure up from that reference sphere, it's going to assign it a red color. It's higher than that reference sphere. So in terms of the elevation display, now saying what's the prediction of how a contact lens is going to fit on the eye, what we're going to say is the contact lens is going to hit the highest spot first, in this case the red, and then it's going to be furthest away. There's going to be the largest gap between the blue, or the deepest depression. In terms of the sea level analogy, the blue are actually below the level of the ocean. We're below sea level, if you will. So if we look at this eye here with keratoconus, what we can see is that the highest spot of this eye is 90 microns above that reference surface, and then the deepest blue is 147, or the grand total difference here in this particular cornea is 237 microns. And you might think that's an interesting number, but what does that mean in terms of actual clinical practice? Well, as soon as we put the contact lens on the eye, instead of using the theoretical reference sphere that's generated in the topographer, what we can actually do is remove the reference sphere and then exchange it for a contact lens of a known brand, a known design from some contact lens manufacturer. It's built within the topography system of the instrument. And then the topographer asks that same question. Does it have to measure up or down in terms of where that contact lens is predicted to fit on the eye? And the high spot is where the contact lens is predicted to hit the eye first. And that's where we're going to have touch. Where the low spot is below the level of the ocean, we're going to have the greatest amount of fluorescein pooling in that area. And in terms of this particular contact lens design on this particular eye here with keratoconus, you can see that we're going to touch here kind of horizontally. We're going to get clearance in this case of about 25 microns, which is just excellent. And then if we switch the profile line to be in the vertical direction, what we can see here is that the lens shouldn't touch anywhere along that meridian. So the lens should move very freely with blink. So this kind of checks all of the boxes in terms of the ideal contact lens fit. We're going to get touch along the horizontal. We have clearance in the center of the contact lens, and then we have the ability for the lens to move unobstructed in the vertical meridian. So though this eye has irregular astigmatism in terms of the axial display, and we know there is asymmetry in the cornea in terms of its elevation, this patient is predicted to wear a corneal contact lens quite well. Well, what's the kind of line in the sand that we draw in terms of success corneal contact lens versus maybe we should be putting a patient into a scleral? So this then is a study that was done at Pacific, and in terms of a prospective fashion, what we did is we fit patients that were referred into the office to see us for specialty contact lens care. We were going to fit them in corneal contact lenses first, and then if we weren't able to, okay, fine, they've just won the right to wear a scleral contact lens. So in terms of those individuals that were able to be successfully fitted in corneal contact lenses, those individuals that had 350 microns of elevation difference along the greatest meridian of change or less, 350 microns or less of change, had an 88% chance of being successful in terms of a corneal contact lens. Those individuals that had greater than that, more likely were going to be successful in scleral contact lenses. Let's kind of add a little bit more life to this. Let's look at a couple different case examples. So here we have an individual with keratoconus based on the axial display. In terms of the elevation display now, along that greatest meridian of change, we go from a high spot of 180 microns all the way down to the lowest spot identified in blue here at 110. So we have a total now of 290 microns of difference along that greatest meridian of change. And this is a patient that's predicted to probably do really pretty well in terms of a corneal contact lens. What about this individual here? Here's another individual with keratoconus, and this patient now has a grand total difference of 655 microns of change. And this is a patient that, in terms of a corneal contact lens, probably isn't going to do all that well, because you're going to get touch in one area, a bubble in another, significant edge lift in one area, minimal edge lift in another. This is the lens just going to rock and pivot on the eye and really not perform or be all that stable on this particular cornea. So now what we're saying is the cornea is irregular enough that the cornea can't support the physical fit of a corneal contact lens, and we're going to now need to fit the patient probably into a scleral contact lens. So what we're trying to do here is really kind of build the story, build the case of when is it appropriate to put the patient in a corneal contact lens, and maybe when is it appropriate to put a patient in a scleral lens. And then knowing that information, if a scleral contact lens, maybe you started in the scleral contact lens and it seems to be failing for some of those complications that we had on a previous slide, and now you're kind of thinking, maybe I should take a step in a different direction and maybe fit that patient in terms of a corneal contact lens, using that elevation display map on your corneal topographer can really be a helpful guide in terms of allowing you to kind of pivot directions and putting them in another contact lens that still corrects their vision, still compensates for their irregular astigmatism, but allows them to be successful in a corneal contact lens. One of the things you might think is, okay, corneal contact lenses are definitely an option, but my patient was initially motivated to be in a scleral lens because of comfort. We know that scleral lenses, relatively speaking, don't move all that much, so initial comfort, long-term comfort can be kind of awesome. So how can we get a corneal contact lens to be more comfortable for the patient? One of those options is piggybacking, and piggybacking is where we take a soft contact lens, whether it's a daily disposable, a 2-week, a monthly, or even a custom soft contact lens potentially for piggybacking purposes, and apply that to the eye first, and then the patient's rigid lens is fitted right over top of that. And this gets most often utilized for individuals for comfort. The other thing that we can use this for is managing some of the complications related to corneal contact lens wear. We'll see here in a coming slide. And the other potential that we could use soft contact lenses for piggybacking is we can actually use them to alter the shape of the eye. More on that in just a little bit. So what do we have here? We have an individual with a history of keratoconus, and you see that inferior steepening with the relative superior flattening, which is just classic in keratoconus. But what about in terms of the elevation display? Is there anything on the elevation display that can give us, kind of guide us, give us some prediction on where that corneal contact lens might actually fit or position on the eye? One of the clues that I said earlier was the contact lens is predicted to hit first on the highest spot, and in this case, it's sort of up and to our right on this slide, and the blue is sort of down and to the left, relatively speaking. So what we're probably going to say is the contact lens is probably going to hit superiorly and then probably move in the inferior direction. So that's something that we might battle just a little bit, and that's something that we're probably going to have to anticipate in terms of the physical fit of the contact lens. But as long as the optical portion of that contact lens is centered over the patient's visual axis and their pupil, the patient's vision should be clear and consistent. So I mentioned earlier that we can use the soft lens in terms of piggybacking, not only for comfort improvement, But also, we can cover over some of these GP complications. One of the more common complications is 3 and 9 staining. So just by putting the patient in a soft contact lens and then the GP over the top, we get that smooth, even soft lens to hold moisture over the patient's eye during the daytime. And oftentimes we can eliminate 3 and 9 staining or even decrease the chance of vascularized limbal keratitis, sometimes referred to as VLK. So what type of soft contact lens should we be choosing? In an ideal world, we would like to stick with a lower modulus contact lens. That lower modulus, all that means is the lens really doesn't have much stiffness to it. The soft lens is, relatively speaking, fairly soft. So there are many daily, 2-week, 1-month contact lenses that are available. There are even custom soft contact lens materials that are, relatively speaking, fairly low modulus. So the reason why we want to use a low modulus contact lens is because of the forgiving nature of the plastic. You're going to be able to fit over a wide range of corneal profiles. And in this case, like we're talking about, this is a patient that has irregular astigmatism because of keratoconus. So here's an image of that soft contact lens on the eye, centering fairly well. We don't have fluting or buckling, sort of edge standoff that might be possible in terms of an eye with keratoconus. So, and then the next step is to really just fit the contact lens right over top of that soft contact lens. You can do corneal topography over the top of the soft contact lens to allow to kind of guide you in your decision-making process in terms of keratoconus, that you have enough steepness to be able to satisfy the steepness of their cornea. The top 2 images are flat to the point that we're actually touching the apex of the cornea, which we don't want to do in keratoconus, and it's really that bottom image. The lens has enough steepness to just clear over the patient's apex of their cornea, and our initial prediction did come to be true, or we kind of predicted that lens would probably ride a little bit lower based on that elevation display of the topography, and that's exactly what ended up happening. But like I mentioned, this is an individual that has the optical portion covering over their visual axis and their pupil. Well, I mentioned a little bit earlier that one of the things that we can do in terms of soft contact lenses for piggyback purposes is we can actually use them to alter the shape of the kind of corneal profile. And what I mean by that is we can actually change the power of the soft contact lens to change the topographical final result. So what do we have here? We have an individual that has a history of radial keratotomy and has left them with not only a mild amount of irregular astigmatism, but has left them with some visual fluctuations. The stability of their vision isn't ideal morning, afternoon, and nighttime. So what we're motivated to do is put the patient into a rigid contact lens of some kind. But if you have a patient, whether it's radiokeratotomy or LASIK or PRK or some other form of refractive surgery that's left them with a non-ideal corneal profile, what piece of information do we use in terms of the corneal topography to guide us in our initial contact lens selection? Do we kind of fit them off of flat K like you would in a normal corneal lens? Do we use some other portion of the corneal topography to guide us in our lens selection? Let's kind of look at this a little bit more carefully. So generally speaking, in terms of corneal contact lenses, we use our central K values to guide us for the initial base curve. And in this individual who we going to be putting them in a soft contact lens for piggyback purposes, most of the time the soft lens power that we elect to use is something low, +1/4, +1/2, -1/4, -1/2, something like that. And in so doing, we really minimally alter the shape of their eye. So if we use the central K value in this patient where we've had them in a soft contact lens of +1/4, you can see that centrally we have a curvature of 37.5 diopters, or 9 millimeters. So if we use that initial base curve, it's actually so flat that it doesn't have the ability to grip onto the eye, because relatively speaking out here, it's steeper. So the lens just doesn't have enough curvature to grip a hold and stay onto the eye. So what if we used this value? What if we used this parameter out here of 43.25? Is that maybe the better base curve we should use in terms of our corneal contact lens? Well, certainly we're going to touch that area of the eye. We're going to get much better centration to the contact lens, but now in the middle, we're actually going to be so steep that we generate a bubble. So what do? How do we solve this? Well, if we know that we're going to be placing the patient in a soft contact lens for comfort, for example, what we could do is actually choose the power of the soft contact lens to be plus in nature. And making that soft contact lens plus, all that means is that the soft lens itself is thickest in the middle and then thinnest in the periphery. So if we repeat the corneal topography right over the top of that, in this case, +6 monthly soft contact lens, you can see here that in the center, now we're 43.25, and then out here in the periphery, we're relatively speaking pretty similar to that. So if we were to try back on that 43 diopter, 4350 diopter contact lens, what we can see here is that we've got a good centered contact lens, and now we don't have the bubble when we piggyback them with that +6 lens. So this truly is a system. The patient is forced to wear these contact lenses together. When you've used the power of the soft contact lens to alter the topographical profile, what we need the patient to understand is that they need to wear the soft contact lens and the rigid lens together as a system. Oftentimes, when we're doing piggybacking, the soft lens power that we're using is, again, something low, +0.5, -0.5, which really, for the most part, doesn't alter the topographical profile too much. And in that example, a patient could use the soft lens some days they don't. It's sort of independent of needing to wear the lens, the soft contact lens that is. But in this case example here, where we've used the power, this high plus power, to alter the shape of their eye, the patient truly does need to wear it as a system. So we've talked about corneal lenses, we've talked about piggybacking. Arguably one of the most common forms of irregular astigmatism is an individual with keratoconus. And are there other things that maybe we should or could be exploring outside of scleral lenses when maybe our scleral lens isn't working so well? We're in our scleral lens troubleshooting process and we're not able to get the patient to be successful. One of those other modalities, one of those other forms that could be helpful are actually soft lenses for keratoconus. And you might kind of initially be thinking here, soft contact lenses and keratoconus really don't go together in my mind. And you'd be right, because remaining now and into the future is going to be a rigid contact lens of some kind as the primary form of vision correction. But there are some things that we can do in terms of soft contact lenses for keratoconus. Now, all of these soft contact lenses for keratoconus specifically are custom in nature, so it can get a little bit complex on how it is that we're going to be prescribing them. So let's kind of break this down a little bit. So the lens is constructed with two primary curves on it, and that is to say that it has a central base curve, and then it has a kind of a peripheral fitting curve, the haptic, the supportive portion of the contact lens in the periphery. So how do we determine the initial base curve? Well, it's suggested that we take the patient's steep K, flat K, add them together, convert that to millimeters, and then, flat K, steep K, add them together, divide by 2, convert that number to millimeters, and then add 1 millimeter to that number. Where did that number come from? What that's based on is custom soft lens manufacturers looking back at what are those successful central base curves that resulted in a final contact lens prescription, that actually resulted in a supply order for the patient. So, and then the fitting curve, that haptic, the supportive portion of the lens, is left of some normal value, 8.3, 8.6, 8.9, something like that, because we know that the peripheral portion of the cornea and sclera is really unaffected by the condition of keratoconus. In terms of diameter, well, since this is a custom contact lens, we can order kind of whatever we want. Most of these lenses, however, end up being toric in nature. So generally speaking, around a 14.5 millimeter soft contact lens is where most of them end up being. So let's look at a bit of a case example or two related to this. Here's a 50-year-old male who has a history of, in this case, corneal contact lens wear for his keratoconus, but really intolerant to them because of comfort. And you can see right eye a little bit more advanced than the left, and manifest refraction you see there, a little bit of plus with a fairly significant amount of astigmatism. Now hang on to this plus here for just a little bit. We'll come back to this in a second. It's going to be important to look at what happens in terms of the soft lens power in just a little bit. But what I want to also draw your attention to is the visual acuity here in terms of glasses correction, really not that great. So glasses aren't necessarily an option for this patient. So here are those calculations for that central base curve for right eye and left eye for our patient. We take mean K, convert it to millimeters, and then add 1. And so the initial suggested base curve in the right eye is a 6.8, left eye is a 7.9. Now, recognizing that the central base curve is only over this area here, just that central kind of optic zone, if you will, the fitting curve, the haptic, the carrier, the supportive portion of the lens is out here, and that's left of some normal value, 8.3, 8.6, 8.9, something like that. So here it is. This is the final contact lens for our patient, and you see right eye visual acuity 2025, left eye visual acuity 2020. What you notice is the spherical component of the patient's refractive error, relatively speaking, is more minus than it was in terms of their glasses. Why? What's actually happening, and what I haven't yet told you, is in the central portion of the contact lens, over that optic zone, it's intentionally thick. It's thicker than average. Most soft contact lenses that are in the marketplace are, say, a -3 soft lens is about 0.08 millimeters in terms of its center thickness. These contact lenses are 0.4 millimeters, so relatively speaking, quite a bit thicker. Why do they do that? In terms of adding the thickness, what that accomplishes is the soft lens kind of moves away from its softness more towards that non-flexing nature like we get in a rigid contact lens. And now you start to form a little bit of a tear lens in this soft contact lens, and you convert irregular astigmatism into more regular astigmatism. You can see that the patient still has astigmatism correction needed, but it's that tear lens that's formed underneath the kind of, relatively speaking, non-flexing soft center because it's so thick that we generate the need to alter the spherical power, and what it's moved is it's moved in the minus direction. So here is what it is that I'm talking about. We have the eye all by itself up on top, right eye, left eye, no contact lens, and then on the bottom we repeat the measurement of the corneal topography over the top, and you can see, relatively speaking, how much more regular it is. Now, granted, it's not quite the symmetry that we get if we did this over top of a rigid lens, but what we've done is we've converted irregular astigmatism into more regular astigmatism, and we can deal with it in terms of the power, the soft toric power, if you will. So just kind of recognizing that that center thickness is truly just that. It's in the center, and the peripheral portion, the haptic of the contact lens, is left of some normal thickness. So the other thing worth mentioning is that for those individuals that have a scar because of keratoconus, soft contact lenses for keratoconus can really be great for these individuals. And what I'm saying is their vision is limited more by the scar than it is the irregularity in terms of their cornea. So if the patient is struggling wearing a scleral contact lens or kind of failing in a scleral lens, and for whatever reason that is, and you know that their eye is best corrected with a rigid lens, then the scar is what's probably limiting them more than anything else. So in terms of who the in terms of what the patient should be wearing in terms of keratoconus, it's really that initial early patient with keratoconus that does well with these soft lenses for keratoconus. It's also those that are kind of the end stage, the later stage, that maybe struggle in other modalities, but these soft lenses for keratoconus really do well in terms of the extreme patients. Well, hopefully you found this information helpful related to potential contact lens offerings outside of scleral lenses when maybe scleral lenses are failing in your practice. Hopefully these are some tips and tricks that you can use to satisfy a patient's visual needs in some other contact lens modality. And I want to thank the entire CONTAMAC team for allowing me to be here as a part of CLASS 2021.